Excellent.
We are now recording. The date is Tuesday, June 24th. This is the SDOMG and a modern approach to orthopedic care using stem cell therapies with Dr. Chris Rogers, Dr. Evangelista, and Dr. Harmon. So take it away.
Yeah, great. So thank you everybody for taking the time to join us. If you have friends who want to see this presentation, we will record it and publish it on both the uh, SDOMG website and I imagine it'll be on the PSC website as well. I'm Chris Rogers. I've founded San Diego Orthobiologics Medical Group here in Carlsbad and medical director for personalized stem cells. I'm joined by my colleagues, Dr. Edmund Evangelista, who is also a physiatrist and fellowship trained in sports medicine here at this office, and then Dr. Bob Harmon, so Dr. Evangelista and I only work on one species, but Dr. Harmon is trained to work on many species. And he's a veterinarian and also a CEO of a company called Personalized Stem Cells, as well as VetStem, and really just a pioneer in the stem cell industry. So we're grateful to have you here today as well.
Glad to.
And so this is the medical practice, San Diego Orthobiologics Medical Group. We're now about 8 years old, and there's a QR code if you want to link to our website. And these QR codes will also appear at the end of the presentation. So if you want to have your cell phone camera ready, you can capture that information. Personalized Stem Cells is a sponsor of FDA-approved clinical trials in the area of stem cell research, principally on orthopedics at this time, but we'll branch out to other medical specialties at some point in the future. And there's a QR link for you as well there. Personalized stem cells would not have been possible without VetStem Biopharma, started by Dr. Bob Harma, who started stem cell therapy in the veterinary medicine space, starting as far back as 2002. So with more than 20 years experience, we've benefited greatly from the technology and the wisdom. So the first question is, what is a stem cell? And we're going to start off by answering some of these questions. Stem cell basic science, translating that science into actual therapy, why you should use your own stem cells, how you can use them now, and what we envision for the future in this space. On the right there, you see a little stem cell hanging onto a blood vessel. So somebody counted recently how many cells are in your body. It's approximately 37 trillion cells. There are about 200 plus different types of cells, everything from your bone to cartilage to tendon. And the question is, how did we get here? Well, of course, we started off with a little bit fewer than 37 trillion cells that had to differentiate into all these different cell types. But even before we were this little guy, we were a ball of stem cells. The stem cell, there are many different types of stem cells, and that's the point I wanted to make next, is that when we first started out, we were just this little ball of embryonic stem cells. And many of us remember late 90s, early 2000s, a lot of the controversy about the use of embryonic stem cells as a treatment. Their primary function is to promote growth. So to get from that single fertilized egg to a young baby, you have to grow a lot of cells. And that's what the embryonic stem cell does. It's contained in the embryo. It has the capacity to self-renew, and it can differentiate into any of the 200 plus cell types in the body. But currently, they're not used for medical treatments and for a variety of reasons. And so I just want to differentiate right off the back that we are today not talking about embryonic stem cells. Instead, we are talking about what's called the adult stem cell, which its primary function is to promote regeneration and healing. So after you have grown up and become a young adult, repair is necessary throughout the remainder of your life, and that's what these cells do. They're found everywhere throughout the body. They've been studied predominantly in tissue derived from fat, bone marrow, or the umbilical cord. Those are where most of the published research will be found using those types of adult stem cells. They also have the capacity to self-renew, and they can differentiate into many cell types, not all the cell types in the body, but many, which is a benefit because these cells will not differentiate into tumors. And the original term was called the mesenchymal stem cell. We'll call them MSCs today. And by the way, the use of the MSC is where we've seen most of the benefit in clinical trials, so for therapy. And their primary function is they're your body's first aid kit. As I mentioned, we're any of us who engage in sports or just life in general are going to have tissue trauma, and that trauma needs to be repaired. So this is part of a system combined with your circulatory system and the cells in your blood to help repair tissue injury when it occurs. So yes, we can repair damaged cartilage. We can repair damaged tendon, disc in the low back. It can reduce inflammation. It can fight infection. Personalized stem cells conducted a study on COVID, patients with COVID. So it's antiviral. The other superpower that the stem cell has is it can boost and balance your immune system. And then it releases molecules that will actually block pain receptors. So there's a whole host of mechanisms by which these cells function, which makes them so desirable. And they can be used for a variety of conditions. We're not going to go through all these conditions, but you can see just about any part of the body that becomes injured by any manner is potential fertile ground for use of these cells as a treatment. And these are some of the areas that are currently undergoing research. There actually are approvals for stem cell therapy. So you're aware that FDA regulates stem cells as a drug and they require approval. They're also regulated in other countries. And we now have more than a dozen stem cell products that have been approved for a variety of uses. And finally, here in the United States, we now have an FDA-approved use for what is called acute graft versus host disease. So children may get a kidney transplant, and the cells in the kidney will attack the recipient, the patient, and these MSCs have been shown to be helpful for mitigating that damage. And so that's 30 years of effort to get that FDA approval for that MSC therapy. So USA is now on the map for that. The personalized stem cell is just one of a handful of companies which has made the effort to pursue FDA approval for stem cell therapies, MSC therapies. And as I said, they're a sponsor of these clinical trials. And we favor the use of adipose tissue. Adipose tissue is a very rich source of the MSC, the stem cell, and it's easily to obtain these cells. I've never had a patient ask me to not take some of their fat away from them. It's something that patients are willing to do. And these cells maintain their potency, and they really do not significantly decline in their number or potency as we age. This is different from bone marrow-derived stem cells, which do significantly decrease in number and potency as we age. And then, of course, the fat tissue can then be brought to a facility. We have a facility here in San Diego where the fat tissue, the cells can be extracted from the fat tissue, and we can manufacture cell therapy. So we'll be talking about that in a little bit. Oh, okay. So our focus has been on treating knee osteoarthritis. This is a very common problem. More than 33 million Americans have osteoarthritis. Over 500 million people worldwide dealing with knee osteoarthritis. And even though we're focusing on knee osteoarthritis because that's where most of the literature has occurred, this would equally apply to shoulder or hip or other joints that have osteoarthritis. So it is a very common cause of disability, and many patients go to end-stage osteoarthritis and require joint replacement. And we think that this technology will substantially reduce the need for joint replacement going forward. There's this high mortality associated with people who have arthritis because of the impacts on your overall fitness level. And so it's not just a matter of having pain in your knee, but it impacts your entire health. And the prevalence, of course, increases as we age. So as we go to our high school reunions every decade, more and more of us will have osteoarthritis in our joints, where the prevalence is about 50% when you get into your 70s and rather into your 80s. And it's also more prevalent in women for some reason. This is what your doctor sees when they look at an X-ray. On the left, you can see the normal X-ray with the joint space between the two bones. As we develop osteoarthritis, the joint space will narrow because the cartilage is becoming diseased or damaged and thins out, and then can start to stress the bone, which causes a lot of the pain that people feel. If you were to look inside the knee, you would see on the left the normal knee with the cartilage on the thigh bone above and the cartilage on the shin bone below with the meniscus, the cartilage pad in between. With damage to those tissues, you can start to see exposure of the bone, which is sensitive and produces a lot of the pain associated with arthritis, as well as inflammation of the lining of the tissue that lines the knee joint. So here we are looking through the camera and see the actual cartilage damage and the inflammation of the tissue in the knee joint. This is actually looking inside a shoulder joint on the left. You can see the surgeon is probing a hole in the tendon with that probe. And this patient was treated with stem cell therapy. 6 months later, you can see that that hole has resolved. This is the same patient being examined 6 months after treatment. So good evidence that stem cells will be helpful for tendon injuries. And the way they work is through two primary mechanisms. We're not going to get into the details, but when patients ask me how do stem cells work, two basic things. One, they're a very powerful anti-inflammatory capability, and then they also have the ability to regenerate cartilage by improving the function of those cartilage cells and blocking some of the molecules that will degrade cartilage. So there's a very robust scientific literature that has fully explored how these stem cells are positively impacting the osteoarthritic joint. And maybe a better way to explain it is the stem cells will put out the fire and then fertilize the tissue to help it to regenerate. So you have the scientific explanation, and then you have the layperson explanation. And this is what it looks like. If you inject cells into the joint, you'll see the cartilage on the left is thinned. That tan color is the bone showing through the thinned cartilage. And then on the right is a year after in the same patient. After a single injection of stem cells, you can see that the cartilage tissue is regenerating, that stem cells functioning as a fertilizer to help that tissue to regenerate. There are multiple placebo-controlled randomized clinical trials around the world. We're not going to go through all of them, but just suffice it to say, here's some of the more well discussed studies where you have placebo-controlled trials where one group will receive placebo, the other group will receive stem cell therapy. And we are now getting to the point where we have studies that have long-term follow-up. This study has 2-year follow-up. There are actually studies that have 7-year follow-up. So since the first discovery in the late 80s and 90s, we're now at the point where we're getting long-term follow-up with some of these clinical trials. So we're pretty far advanced now in our understanding of stem cell therapy and osteoarthritis. And one of the common myths I like to dispel right off the bat is that your own stem cells, regardless of your age, are actually more effective than cells from other tissue types, such as bone marrow or umbilical cord. And are more effective than using other people's cells. So this is the reason why personalized stem cells has focused on using fat cells derived from the patient's own fat tissue. And then finally, another myth that I like to dispel is that stem cells can't. I've heard physicians say stem cells cannot grow cartilage. That's not true. We have this meta-analysis from COP published in Nature journals, a high impact journal, showing in their meta-analysis that cartilage protection or repair was seen in 18 out of 21 of the clinical trials that they examined in this meta-analysis. So we're seeing pretty consistently across all studies good evidence for cartilage regeneration and growth. And then the last study I'll share with you here is this 5-year follow-up study by Kim in South Korea. And you're not used to looking at an MRI, but I can just tell you that the MRI from before the treatment shows very thin cartilage. And then out to 3, 4, and even 5 years, we're seeing thickening of the cartilage. So even on MRI, we're seeing evidence of cartilage regeneration. So Dr. Harmon and I and several other physicians around the country conducted a clinical trial using patients' own cells derived from their fat tissue. This was published in the journal Stem Cells and Development, showing good efficacy and good safety when we use the patient's own stem cells from their fat for moderate to severe knee osteoarthritis. And I like to use the Lucky Charms analogy. What we do is we consider the fat tissue as a heterogeneous collection of cells, as well as other substances in the fat. The processing involves removing the cells. So in this analogy, the marshmallows are the cells. The milk and the crunchy bits have been removed from the cereal. And then if we were to just extract this single blue diamond and grow those in the petri dish in the lab under good manufacturing processes, we can produce a very high number of high quality stem cells. And so now you have essentially a 99.9% pure stem cell product. And this is what's currently undergoing investigation. This is what it looks like in the lab. You can see on the right, the scientists have received a bag of fat, and then they're extracting the cells from the fat tissue. And you end up with this pharmaceutical grade product, which is called culture expanded autologous stem cells. So these are your own cells, a standardized dose, and is essentially similar to any other FDA-approved drug, where you have standardization in the dose, potency, purity, and then also we're assuring sterility of the product. So we know it's a safe product. This is our clinical trial. So the cells come in a bottle. They're frozen in liquid nitrogen. They're removed from the container. So these are shipped directly to the doctor's office while the patient is waiting. And it takes about 20 minutes for that vial to thaw those cells. There's about 15 to 18 million cells in that small syringe. And then using ultrasound guidance, we just place the cells directly into the knee joint. And we like ultrasound guidance because it makes it more comfortable and makes it more accurate and safe. And that's it. It's just a simple injection with Band-Aid, and the patient will be sore for a day or two, and then they can resume their normal activities after that. And we followed their data. We followed our patients now we're actually more than 3 years at this point. But in this slide, you can see that all the lines are going up. That means the scores on pain and symptoms and their ability to participate in sports or activities of daily living are all improving pretty much by about that third month, you can see. And then those benefits are maintained out to beyond 2 years in the vast majority of the patients. And we asked patients if they were satisfied. Most patients were satisfied with their treatment. We did have a subgroup of patients who underwent joint replacement surgery. But when we asked those patients how they were doing at 1 year, 83% of them were happy with their results. So they were getting joint replacement more than a year after receiving treatment. And had they had the option to have a repeat treatment, they all said they would have done it. But unfortunately, we were unable to do that given the restrictions of an FDA-approved protocol. So we believe strongly that patients should bank their cells for repeat treatments going forward. And so we have this stem cell banking program that I'd like to share with you. It's called STEM Ensure. And essentially, these cells can produce hundreds of doses that will last for the remainder of your life. It's a simple stem cell collection through lipoaspiration procedure. As I mentioned, we create a pharmaceutical grade stem cell product with more than 12 million cells per vial. And then it's stored in this FDA registered and federally licensed tissue bank here in San Diego. And these cells remain in hibernation, so to speak, at their current age and health for decades. So the sooner you do this, the better, because these cells are going to be at their most potent level. And then these cells provide a master cell bank for which we can grow additional doses, again, for the remainder of your life. And there are 2 programs that you can ask us about. One's called STEM Preserve, where we simply take the cells and using the analogy of the Lucky Charms marshmallow bits, so all those different color marshmallow bits are stored. That's a quick and easy way to store your cells now. If you want to have stem cells ready to go in the case of emergency, or if you have a need right now, then we have the STEM Ready program, where those cells are cultured to the high number of the blue diamonds, again, using the analogy, so that you have these cultured cells ready to go. And why would you do this now? Well, pretty sure none of us will ever be younger than we are right now. You're the healthiest, perhaps, at this point. There may be an event in the future for which you will need stem cells. And this concept is very similar to umbilical cord banking, and yet the treatment is available for you now. There are options for you to receive treatment in the case of emergency. So there are cases where a patient may have a COVID infection, severe COVID infection, or perhaps a neurologic event like a stroke, perhaps a heart attack, where these cells may play a role. And you would like to have these cells at the ready. And then there are these early access programs that I will share with you, where some patients can gain access to cell therapy now. They basically fall into three categories. You have the clinical trials, which I already shared with you. We have what's called FDA expanded access. Expanded access. It's also called compassionate use. So your physician would submit to FDA on your behalf to offer you this treatment. And then there's the Federal Right to Try Act, which I'd like to elaborate a little bit on right now. So the Federal Right to Try Act was a law passed by the US Congress in 2018. And this law basically empowers patients to gain access to drugs that are considered eligible, but are not yet FDA approved. And to be eligible, you have to have completed the phase 1 clinical trial, which I just shared with you, and be under the current FDA regulatory pathway. So you're in good graces with the FDA. So our current stem cell product does satisfy the eligible drug criteria. To be an eligible patient, you must have a life-threatening or debilitating condition for which knee osteoarthritis can qualify. And so that's why we mention it here. These are for patients who've already considered or exhausted other treatments. So they may have had physical therapy, they may have had a gel or cortisone injection for their knee osteoarthritis, and they're not a candidate for current clinical trial. So if you meet these criteria, you can essentially have access to this program, this federal law that was passed to gain access to cells at this time. So in summary, we believe that stem cell therapy will transform orthopedic care going forward. It's already been proven to be the case in veterinary medicine and multiple human clinical trials. The FDA approval will allow this to be widely accessible to anyone in the US once we achieve that. But there are early access programs available now, such as the Right to Try program. And even if you're not considering treatment at this time, you should at least consider stem cell banking, as I have and my wife have, and most of the people on this call have, because it's just great health insurance, essentially. So if you'd like to learn more about that, you can schedule a call for a 15-minute information call with Corbin May, who's on this Zoom meeting, in working at Personalized Stem Cells. Or you can reach out to any of the doctors here at San Diego Orthobiologics Medical Group. So just grab your cell phone, take some pictures of those QR codes, and you can gain access to much more information. There's some videos on both of those websites you can watch, as well as some clinical trials if you're inclined to read the scientific evidence. So at that, I'm roughly at the half-hour mark. So I'm going to introduce my colleagues, Dr. Evangelista and Dr. Harmon, and I'm going to ask Corbin to dish out questions to us. Did I lose Corbin?
Yeah, I've got the questions up too, Chris. I can pop
Okay,
on
why
it.
don't you
Yeah.
take one there?
So, interesting question. What peer-reviewed studies show the efficacy of this kind of stem cell therapy in osteoarthritis? I know, Chris, you've read every study on the planet and every meta-analysis as well. But this is somebody who's asking because they had patellar autograft and now has pain post-surgery years afterwards. So, is there actually any good literature? And I know you showed some, but maybe you can grab that.
For osteoarthritis in general, yes, osteoarthritis can involve the compartment behind the kneecap, the patella, and having undergone an ACL reconstruction using that middle third of the patellar ligament can predispose you to osteoarthritis. Injury in your ACL can predispose you to osteoarthritis. So the biology is the same,
Yeah.
and so yes, the stem cell therapy would apply to this use case, this specific medical condition, and more than happy to send you as many papers as you're really willing to read that show that yes, we have peer-reviewed, placebo-controlled, randomized clinical trials showing long-term safety and efficacy of stem cell therapy for knee osteoarthritis.
Yeah, and it's interesting. So if you go to the FDA and you ask them what kind of data do they want to see, it's these kinds of studies. But there's another interesting piece. Again, as a veterinarian, I'll throw a little bit in there. The FDA says when they see data in more than one species for the same thing, it adds huge power to their comfort level about the cells really working. And we have studies, I don't know, in at least 6 or 7 different species, dogs, cats, horses, and some exotics with specifically knee arthritis, and showing that yes, we're not magic in people. We're not the only ones that have knee arthritis. We're also not the only ones that get treated with cell therapy. And we've got now, I think, with knees and dogs, more than 5,000 cases over the last 15 years. So there is interesting data. Here's a question for you, Dr. Evangelista. So people ask about how many, when you're putting this syringe in, you're injecting a shoulder, how many cells of these stem cells are actually going in when you're injecting a shoulder or a knee? How many total cells do we try to target?
Well, if we're doing the same day fat procedure, like a microfragmented fat where you do it the same day, you're probably getting 1 million stem cells into the joint. What I like about the PSC program, when you culture it, we're getting like 15 to 20 million stem cells in the arthritic joint. And I think a lot of the studies in PRP at least are showing that dose really makes a difference. So I think those higher doses can get you the result that we're looking for, is what we're hoping.
Excellent. Good. Here's an interesting question I'm going to give to Dr. Rogers. Now, don't go off the deep end here now, Dr. Rogers. Somebody is saying, hey, I went and got an infusion, massive dose of exosomes and nebulized, meaning I got it up my nose with exosomes, and I really there was no improvement. In fact, maybe I'm worse. What are your thoughts on current both safety and legality of something like an exosome, which people don't know is the little thing that stem cells secrete when they're talking to other cells. It's a little packet of information. But
yeah, exactly right. Exosomes are microscopic packets of DNA, RNA, some proteins wrapped up in a nice little membrane that is secreted by the stem cells, actually secreted by many types of cells. But anyway, these exosomes have been promoted as a treatment, in my humble opinion, way before the scientific evidence shows evidence that it's safe, let alone effective. Matter of fact, there's such little evidence that the FDA does not permit it at all. Just Google FDA exosomes and you'll see what the FDA thinks about exosomes. So I hope that treatment was not done here in the United States because it's not permitted. And anytime a doctor does something that's not permitted, I'm a little worried about that doctor. So I won't go off the deep end. I'll just leave it at that. But if you went overseas, say you went to Mexico and somebody blew some exosomes up your nose, you know, we don't have enough data to know if that's effective. And how could we know? It's such a complicated issue. It gets promoted. Exosomes get promoted because this is what stem cells do, right? So, but the basic science is, you have this device in your hand, that's the stem cell, and you working with that. So there's some intelligence, hopefully, to the system. The text that you just sent to your friend, that message is the exosome. So it's just the DNA, the RNA, the encoded message. There's no intelligence necessarily to the text just by itself. So I'm in favor of stem cells over exosome. There are some animal studies that show that stem cells are more effective than exosomes. So I won't go down that rabbit hole, but I'm staying away from exosomes at this point.
Yeah, and Dr. Rogers and I are putting together a paper we hope to publish on the differences between somebody else's cells and yours and the safety. One of the things that happens is, so there are signals, right? Anybody ever watches a football game or a baseball game? And if you get really good common signal and everybody's on the same signal, things work well together. And the same thing is true in the body. But if you get exosomes from this person today and this person next week, these little exosomes actually can merge with your body's cells and they're information packets. So imagine now you're trying to listen to a cell phone with 7 different calls coming in at the same time. The body gets confused and you actually have some I'm a toxicologist. You get toxicology effects, toxic effects from having these mixed signals. And I think we're just starting to understand that. So it's going to be interesting to see. So Dr. Evangelista, somebody just walks into your office and they're doing an MFAT. So they're collecting a little fat and you're going to do an office procedure. And they say, hey, I heard Dr. Rogers say that these cells are good even if I'm old. Why would I even want to save them today? I'll just wait till later and I'll do it later. What kind of wisdom would you give to them about storing your cells now and having them maybe ready now at this age?
Yeah, you know, when I'm doing a fat procedure, a microfragmented fat procedure on a patient with arthritis, I like the fact that, you know, I'm going to take a little extra fat and send it to the lab to store in the event that the treatment we do doesn't help. Then we have that option to culture the cells and potentially have them undergo the treatment of the cultured cells through this right to try act. So I think it's a great way, you know, if we're going to be doing a procedure, harvesting fat anyways, take a little bit extra, send it to the lab to store in the event that we may need it for future use. And once it's there, you have the ability to produce more vials for future use. And yeah, I think it makes sense to at least store it, even if you may not use it right away.
Yeah, for sure.
And the other, yeah, sorry to interrupt. The other
yeah.
thing I'll add, our clinic was one of the first in the country to introduce MFAT treatments for our patients. And so we have over a decade's worth of data now. And it's pretty clear that we're not curing osteoarthritis. So you get around that 3, 4, 5 year mark, most patients are going to need a repeat treatment. And if you already have cells in the bank, then you don't have to go through that whole rigmarole of doing the liposuction again. You actually have in my opinion, a higher quality product ready to go in the bank. So most patients, almost all, will need repeat treatment at some point down the road. So it's insurance.
The other thing is really important, right? We all have experience with family and friends. Somebody gets a disease. For example, they get leukemia, a blood cancer. They get COVID. Heaven forbid they get some kind of virus like an AIDS virus or a hepatitis virus. The things that circulate all around your body contaminate your whole body. Then you actually can't go in. Even though your cells might be young, they might still be really good. Now you can't use your own cells, so you're going to be relegated to using somebody else's cells from a bank, and the risk around getting what diseases might be there and having that signaling problem. But, you know, I have exactly this thing that has happened in my life. One of the veterinarians that's done more than 500 cases in veterinary sort of was watching and saying, okay, well, I'll get mine someday if I need them. He just got cancer. Now I can't use his cells. He's going to have to, if he's going to get treated, get somebody else's cells. And you have, again, all the risk of having somebody else's cells. So having them, for sure, as Dr. Evangelista said, right now you're already doing a procedure. So you've got the fat, literally, you're going to throw it in the trash if you don't use it, if there's excess, and so you can collect it now. It's a convenience sample. If you got a knee replacement or even a knee scope where you're having some repair done that is a surgical case and needed, again, grabbing that fat there, maybe you use it in the other knee later. So
You answered one of the
yeah.
attendees' questions is why, if the stem cells don't decline with age,
Yeah.
and it's not true, they do, but
Yeah.
not very much. Why bank now? And it's
Yeah.
for all the reasons you just mentioned.
Yeah.
There's some really good questions. How long does it take to manufacture cells? So I have my fat collected today. You take 4 tablespoons of fat out of me. How soon will I have cell? You maybe talk a little bit about the processing.
Sure. So the initial collection is done obviously same day. That little small collection, the harvest of the cells, is this mixed cell Lucky Charms population there, and we need to clean it up and also expand it so you've got enough for repeat treatments. And so that process takes about 3 weeks. We're literally going through growing them, expanding them, so we've got them multiplied, and you go from 1 million cells that might be in that first collection to hundreds of millions of cells to make these doses that we can then freeze. That's about 3-4 weeks for the cells to grow. They grow pretty fast. Then we take another month and we do a lot of safety testing, make sure it's sterile, doesn't have anything else in there. All the kinds of testing that is required by the FDA to know that this is a fully safety tested product that we're putting in these vials. So it's about 60 days. Now, the other end then, now when Dr. Rogers calls and orders up for a new patient or for somebody that got treated a year ago, or yeah, I think you've got one coming up in the next couple of weeks, they were treated 5 years ago in our clinical study. Their cells are still active. Literally, we take them out of the freezer, put them in a little shipment box, and then they're immediately available. So there's no additional time involved. It comes frozen like a popsicle, and it's very cold, and then you pull them out from that picture you showed, Dr. Rogers, at the beginning, and they just sit on that shelf for 20 minutes. Nothing special. When they're thawed, you can inject them. And so then they're available literally within hours if you were local to where the cells are being stored, or certainly overnight in an emergency, they could get to you. Yeah. There's a lot of questions on backs. And
Yeah.
I know both of you are highly trained in dealing with necks and lower backs, and maybe you want to comment about intradiscal injections and how cells might even be deployed for somebody with pain in their back.
What do you think, Ed? What are your thoughts about? So I don't know if you're aware, Dr. Ombach just treated the first ever, I think this is the first ever patient in the United States to receive intradiscal autologous MSCs for
Yeah.
a disc tear.
Yeah.
Yeah, I'm pretty excited for using it in discs.
Yeah.
Because the problem we have with lumbar disc or cervical disc is the dose we can achieve getting, if we do PRP or if we do bone marrow, we're not getting a high enough dose of stem cells because the disc only hold 1.5 cc's. So if we can just get these cultured stem cells where the dose is so high and just inject a tiny volume into that disc, I think that's really going to be a game changer for disc-related back pain.
I agree.
The other thing I didn't think about, and Dr. Rogers uses this example, and it really sticks in my brain. Anybody who's old enough to remember The Wizard of Oz and Tin Man, and here, oil can, a little bit here, a little bit here, a little bit here. We didn't have that option before. Now with multiple doses stored for a patient, how would you use that for the thing that's so complex that we just call the back, but it's a lot of complexity.
That's very true, and there's good evidence now showing that these patients with chronic back pain don't simply have one tissue problem. It's not just a torn or bulging disc. It's an irritated or damaged nerve. It's a joint that's too loose because the ligaments are stretched out or damaged, or they have arthritis in their joints. So it's backs are complicated. I mean, they're common, and they're commonly treated badly around the world, really. So this can transform that in a big way.
So what about these little digits? I mean, we talk a lot about the big joints for walking around or a shoulder. And as you know, Dr. Rogers, I'm a shoulder patient. I had a bad rotator cuff tear, but we all will get hand pain, thumbs, fingers, toes. Does it work in those kind of joints as well?
Yeah, we have some limited evidence on the use of what is a commonly involved joint right here called the carpal metacarpal joint, or CMC joint. Is where your thumb attaches to your wrist, essentially. That's probably the fourth most common joint in the body to get arthritis after hip, knees, and shoulder. And there's some good data showing that cultured stem cells can be effective for treating arthritis of the thumb. Dr. Evangelista and I have been treating with platelet-rich plasma for the milder forms of arthritis, anywhere in the body, spine, thumb, shoulder, hip, knee. And it's not so much which joint, it's how bad is the damage. How long did that poor patient wait and suffer before they came to see us? So the longer you wait, the more damage there is, the less likely we are to help you. However, the encouraging thing, like I said, in a study where we published with knee osteoarthritis, we had pretty severe knee osteoarthritis patients, and more than 3 out of 4 patients significantly improved for years. So but having said that, the success rates can be even higher if we catch it earlier.
Agree.
You both have experience with treating a lot of patients, and now in this last year, through PSC, we've got data now coming in on more than 100 patients treated under this federal right to try. What's your experience with how long it takes before a patient will see some effects? I'm glad to jump in after that and tell you the veterinary experience, because we've got now more than 20,000 and a lot of data. But if you got your hips injected, you got your knee injected, how long before you start seeing benefits?
Yeah, Ed, you have some experience. I was also going to ask you, Ed, about how, what the time course is like immediately after the injection. So you get the treatment,
Right. What happens?
what happens after, and do you restrict the patient, things like that. So let's just maybe cover the whole time course. But
Yeah, I haven't done enough of the PSC injections to give you a good time frame of how fast they improve. But I would typically say about 3 to 6 months is that window where we'd want to see start seeing improvement.
Yeah, I agree. So I do have some experience, and it parallels very closely what we've seen with other treatments. The only difference is that this subgroup of patients who are qualifying for special programs all have severe disease. So we don't have anybody with mild shoulder arthritis. We don't have, I mean, we have people with, giant bone spurs in their shoulder, no joint space on their x-ray. So honestly, I can say that almost every single patient, with the exception of one that I can think of, has improved to varying degrees of improvement. And that improvement generally occurs at around the 90-day mark after treatment. There are a couple of early responders, a couple of patients who I've seen, a couple of ankle patients, for example, I've seen improvement within the first few weeks. I've had a handful of patients where it takes a little bit longer than 90 days, but I think there's something magic that happens at that 3-month mark where patients are symptomatically and functionally well enough that they notice significant improvement. Immediately after the injection, I don't restrict the patient other than use common sense. If it hurts, don't do it kind of thing. But they're generally sore for 2 to 3 days after pretty much any injection we do for them, whether it's PRP or MFAT. And the same is true with the cultured cells. But, so far safety is excellent. We've had 0 safety events. And I don't expect any, frankly. I can't think of anything safer than your own cells.
Yeah, we see in veterinary, because we've tracked a lot of data, and we do a 90-day, 1-year, 2-year kind of data, and we do see some early responders that from the pain effect, but we're not growing cartilage in a week or 2 weeks. But you do get some reduction in inflammation, which patients will see a benefit fairly early on. But then as the cells get engrafted and they're stimulating all the repair that goes on and turning it from an on fire picture like you had, Chris, on fire in the joint, to being cooled off, and now you've planted seeds and it's starting to grow. Then you see that sort of the second wave, and you get that improvement. We've even seen patients that out at 90 days, they had a little improvement, but not a lot. But by 9 months or a year, they had fairly dramatic improvement. And some of those papers you showed out of South Korea, out to 2 years and 3 years, getting continued improvement. But because we have these cells stored, you also have the ability to give boosters. So, you got great, you got to here, you can come back again. And we have athletes right now that are coming in and getting treated that are coming back like that. And they're not waiting till they get pain. They're saying, hey, I'd like to get better than I am now today. And you can come back and get your cells again for a repeat treatment.
Yeah, a lot of patients will ask me, they'll say, should I do this once a year?
Yeah.
And I said, the data doesn't really suggest that, although it might be a good idea. But the data is suggesting that, see how long you get from one treatment. So say you go 3 years, 4 years, 5 years, you're doing well. Maybe at that 5-year mark, you're saying, pain's coming back and my knee's swelling, or more often than not, someone will say I overdid it or I hurt myself again. That's why rehab's so important, because not only do you have to heal the tissue, but you have to strengthen the joint. So both of those are key. But if you do a good job, you can pretty much stay away from trouble for many, many, many years. I would say maybe 2 out of 10 patients will get a booster shot within that 3 to 5 year point.
Yeah.
But everybody's different. Every patient's different.
Yeah, they're different. Dr. Evangelista, you've mentioned, and both you guys have mentioned MFAT and NanoFat. That's a confusing thing. And several questions have come in saying, are you using that? And what is this? I think maybe just repeating what those are and that point of care you're doing it same day versus what this is when you get your cells sent to the lab and expanded.
Yeah, so the same day procedure is we harvest the fat and then we rinse, wash, concentrate it, centrifuge it, and then micronize it. And that's microfat or microfragmented fat. That's typically what we're using in the clinic. We're not using nanofat. Nanofat is where they take that microfragmented fat and make it even thinner and emulsify it more. If you're injecting more, that's usually more used for aesthetics, I believe. We're not using the nano fat with orthopedics very much because we actually like using the micro fat or micro fragmented fat when we're injecting a tendon tear that has a big gap to fill that gap. And plus, when you do the nano fat, you're also probably losing some of the cells in that process when you're, making it more fine.
Yeah, I think you're right. I think I can't remember the name of the doctor who developed the name Nanofat, but Tennard, Dr. Tennard, who uses it mostly for plumping up your face or taking the wrinkles out of your hands, that kind of thing. It's a misnomer because it's not really nanometer. It's not nano size fat fragments, but the point is that they're breaking up the fat into smaller pieces that allows the cells better chance of getting out of the fat graft and doing their job. But there's challenges with the technique. That's why I've converted more from microfragmented adipose tissue to cultured cells because it's a standardized dose and standardized safety, sterility. I mean, it's just a superior product in every way.
Yeah, and if you were getting microfat and you needed to get retreated, you have to go in for another harvest. And again, it's a minor procedure, but still having to go back for a second harvest or a third harvest because this is your toolbox for going forward in the future. Which leads us to an interesting question, been several of them on both the cost and insurance. Let me give you an insurance comment from the veterinary side, and then I'll let these guys describe the costs and sort of the process of doing that. But in veterinary, we went literally 15 years ago, as we were 5 years into this program, to the veterinary insurance companies. And all of them, anybody who's got insurance on their dog or their horse, it's the same companies. It's the veterinary division of a big human insurance company. And we presented the real data, the data Dr. Rogers is collecting today in data biologics, that kind of data. All of them covered in veterinary, no questions, because it's cost effective compared to getting big surgeries and long-term chronic diseases. But currently, they're not covered. This is not an FDA approved program yet, and so insurance companies are just starting to look at it. So it's a cash pay today. So you might then describe what is the expectation for kinds of costs for the whole program.
There's the physician fee and then there's the lab fee. So depending on which of the STEM banking programs you do, there's different tiered systems for that. We can get you that information. If you just scan that QR code, that gives you an appointment with Corbin, who run through the numbers on the lab processing side. On the physician side, there's a fee for collecting the adipose tissue. So it's a mini procedure, lipoaspirate procedure. I think we charge somewhere around $2,000 for that procedure. And then there's the cost to inject. And the injection cost depends on how complex or how simple we're doing. But, it could be in the range $4,000 or $5,000 for, some injections, depending on how complex it is. So it's not inexpensive.
Yeah.
And I have to, I have this conversation with my patients all the time. In my opinion, from a scientific perspective, we don't have a more superior stem cell product anywhere in the US, probably in the country. We have a lot of data showing that high dose stem cell therapy is the most effective way to treat osteoarthritis non-surgically. So it's a high quality product. There's a lot of people leaving the country, unfortunately, getting inferior product, or maybe it's a good product, but they're getting inferior medical care. And at a minimum, they're not getting follow-up care because they're not living in that country. So they're not having that long-term relationship with the physician. When I treat a patient, they're stuck with me for at least a year. I'm, working them through their program. So, and we tweak it as needed. So that medical care is big part of it. The rehab, the physical therapy is a big part of it.
You might
Um,
talk, Dr. Rogers, just like somebody now calls you and says, I want to make an appointment. I want to learn about this. What do they go through the meetings with you, the approval process, and then getting to treatment? What's that patient journey like?
So if they're local, a lot of times we'll just schedule an appointment, and that appointment's covered by their insurance. So it's an hour-long consult usually. And then if they have imaging, how one person asked Ed, how old can their imaging be? Do you have a
I would say within 2 years, unless something has changed or, in that
Yeah,
time period.
I
yeah,
agree. I agree. The imaging is helpful. I know a lot of doctors will do injections without the imaging. I
yeah,
think,
yeah.
we're spending all this time, energy, and money. Let's make sure we fully understand and define the problem. Yeah, you have arthritis, but you might also have a ligament or two injured. You might have a meniscus injury. There may be some other associated tissue injuries that we want to address. So, first step is to get a comprehensive, complete, accurate diagnosis. You can only do that with, physical exam, looking at the imaging, taking a full history. Once you have that, then you run through your pros and cons of each treatment option. Not everybody needs stem cells. Some people will benefit from just PRP. If you sprained your ankle yesterday, we're not going to do any of this stuff. We're going to do standard of care rehab, get you through that first 6 weeks. If that injury doesn't heal, then we're going to start talking about some of these other therapies. So, that process, just schedule an appointment. It can be done in person in our office with Dr. Evangelista or myself, or we'll do Zoom like we're doing right now. Like we have a lot of patients from all over the country. We'll do a Zoom call, and we'll run through that. And then if it looks like they're a candidate for what we offer, they'll fly out. We'll do our exam and then do our treatment. And then anyway, so that's sort of
Yeah.
a review.
Good. And there are several questions on the amount of fat you harvest, and maybe the difference between if you're doing a procedure where you need a lot of fat to do the treatment today versus getting a smaller amount to get it's just going straight to the lab and being used there.
Well, normally Dr. Evangelista and I try to get about 4 tablespoons, 5 tablespoons, so like 40, 50 mLs of lipoaspirate, which is enough. We've been able to culture cells from smaller samples than that. There's been some patients that are very lean. They really don't have much fat on them at all. The other option that we are exploring, of course, is if anybody on this call is going to get their knee scoped or getting a knee replacement or something, that surgeon can take some fat from the joint at the time. There's fat in the joint, and that fat can serve as the stem cell source. It's actually a very good stem cell source. And that sample can go to this lab here in Poway in San Diego, and we can get a lifetime supply out of just that little sample. So you don't need a lot of fat sometimes.
Hey, how long do these cells keep working? The common question. Yeah, I think you addressed it a little bit, but maybe bring that. How long do we see the effects in a patient after they've had their cell therapy?
So there's usually two questions. One is how long do the cells stay in the joint? And then the question is how long does their effect last? And, it's analogous to a cortisone shot. Why are we giving you a cortisone shot? To calm down the inflammation in the joint. How long does that cortisone stay in your knee? Stays in there for about a day. Your body, I don't think people think about this, but you take a pill or you get a cortisone shot, your body's excreted most of those molecules within 24, at most 48 hours. Even the gel injections, we used to tell patients, oh, we're going to cushion your knee. We're going to put a little hyaluronic acid gel in there. Baloney. That gel's out of your knee in 2 days. So there's no cushion. What it's doing, the easiest way to think of it is biology and physiology is complex. And think of them in terms of a bunch of dominoes. The cells are kicking off that first domino. Once that first domino is kicked off, you don't really need the cells to be in the joint. It's helpful, but you don't necessarily need them to be in there the rest of your life because they've started a biologic process that the other cells and tissues in your joint are taking over. And so, for example, if we inject a stem cell in your knee, it's going to physically attach itself to your cartilage cell, inject mitochondria and some other molecules into that cartilage cell. So now that sick cartilage cell becomes a healthy cartilage cell. So you don't need that stem cell around anymore. He can be gone in 6 months. That cartilage cell is now functioning normally. So it's jump starting the process.
Good. I think we're down to about 3 minutes left to the top of the hour. Are there any other items that Dr. Rogers, Dr. Evangelista, you want to hit on that we've not gotten? There's some other questions we haven't gotten to, so we can finish up with a couple of those. But anything you think is just like
First of all,
that you hear all the time in the clinic?
Yeah, the most common questions are, what can I do after the treatment? And the answer is pretty much anything that you're comfortable doing. There's no restrict. This is not surgery where we're trying to protect hardware or anything like that. So those cells can function while you're abusing them. I mean, you're sitting on, half a trillion cells right now. They're doing just fine. They can handle abuse. The other question we get is, like you say, when will it start to work? It's usually around that 3-month mark. Will I need to do therapy? Yeah, we should all be exercising. Will I need a treatment again? Usually if it's a tendon, usually the tendon will heal and you don't need repeat treatment. That's different than osteoarthritis where patients might need treatment in another 3 to 5 years. The cost is high because there are very few people that have the luxury of doing this right now. But once it becomes widespread and insurance covers that, then obviously the cost will come down. But it's less expensive than if you were to go to outside the country right now and spend, $25,000, $30,000 on who knows,
or $80,000. I just got back from offshore looking at a clinic for somebody, and the amounts you spend, and then you're getting, in almost all cases, you're getting somebody else's cells. Yeah. And so you really don't know, where did those cells come from? Are they clean from viruses? So and people are desperate and they go looking for treatment. It's why we really pushed hard here to help people get qualified through the Right to Try Act here when they have significant orthopedic problems, and they can get treated then at home.
Yeah. So Dr. Evangelista and I are excited about cell therapy in general, but cultured cells specifically for all the reasons we've already stated. It for sure is the future of orthopedic healthcare. It probably will play a huge role in healthcare in general. There's a lot of hurdles. We got to get FDA approval. We got to get doctors trained. We've got to get standard protocols in place. And we need to know where it works best and where it's not going to work at all. So there's a lot of work ongoing. There's more scientists alive working on this than ever have been in our history. So expect to hear more and more about this.
Excellent.
Well, thank you everybody for taking the time to join us today. If you have any questions that we didn't address, feel free to reach out to us. We'll answer by phone or email or schedule a consult. If you have questions specifically about stem cell banking, use that QR code that I shared with you, or just go to personalizedstemcells.com and you can schedule an appointment with Corbin, who will answer all your questions. Thank you again for your attention, and we'll catch you next time.
Thank you, everyone.
Thanks.